Okay, hello. I believe most of you are একজনকে দেখতে পাচ্ছি. Some of you are from our hospital. The others are okay. Hello, welcome. We had to do with a topic which is care of trauma patient. Now, this is best handled in a presentation. For as a skill station, there are only few things to deal with. So I'll give you a scenario. সবাই দেখতে পাচ্ছি? Thankfully, there are a few boys because my video is no longer working. There is no internet, so I'll need a volunteer also to show you things. Okay, I'll give you a scenario. A 24-year-old man falls off the back of a truck and hits his head. On arrival in your hospital, he is unconscious, and his breathing is noisy. Now, questions are: how would you assess his airway quickly? What are the signs of airway obstruction? How would you open his airway, and how would you immobilize his cervical spine? So, even there is a quick assessment, airway or anything, it's vitally important that we immobilize the cervical spine. Otherwise, what can happen? Yes, if there is an unstable cervical spine injury, the patient may become paralyzed, paraplegic. So, are all of you aware what this is? What is this? This is a cervical collar. We also Philadelphia collar. Can anybody show me how to put a Philadelphia collar on? Anybody? Any volunteers? Ready? Anybody? What are the parts of the collar? Okay, first you have to identify, show your colleagues what are the, which part is which. Back part, this is the front of the collar. How do you put it on? I will need a volunteer. Anybody? Anybody will volunteer? No problem, just come and line out. Any of you, any of the boys. Come on. আচ্ছা তোকে তো এদিকে যেতে legs straight please. Yeah, lie down. Okay. Is this all right? Is this okay? Has she done it rightly? No. Identification is no problem. You know what things are right, but whether if the steps are right. What did she not do? Yes, neck. Right? What with the neck? Yes. What will that person do? Yes. Neck has to be immobilized, right? And then what do you do? Slip in. No. Yeah, do it. Even do it with one end articulated. That's all right. Do it. No, not from the sides. Yeah. ঠিক আছে, we understand. সবাই দেখতে পেয়েছে? Has all of you seen? After you have immobilized the neck, what do you need to do? Patient has arrived in the ER. You have put the collar on. Then what will you do? Then you will transport the patient to your bed. How do you transport this patient? You have to put the patient on a Spinal board, spinal transport board. Now, how do you put the patient on the spinal board? No, not log lifting, log rolling. Is log rolling? Then the cervical, the spinal board is put back in, cause paralysis. Airway assessment. How do we assess airway? What is the easiest way of assessing airway in a trauma patient?
If he is talking,
Yes, if the patient is able to talk, that is the surest sign that there is nothing wrong with the airway. On the other hand, patient may be having noisy respiration, maybe hoarse, or even may not be able to speak at all. If a patient is unconscious, as here appeared in this case, suppose there is no noisy respiration, how do we know that the patient's respiration is all right, or there may be some problems with it?
chest movement,
We monitor, right? So when you get such a patient, what do you do first? You put in a right. You inspect how his respiration is, how his chest wall is moving, whether both sides of the chest wall are moving equally. If you get a saturation maybe above 90%, maybe even 95%, then his breathing, whatever may be the underlying injury to his lung, if any, his respiratory system is able to maintain oxygen saturation, right? And if it is not, what do we do? Suppose there is noisy breathing, there is desaturation, patient is unconscious. What do we do?
start moving.
Right. What's the steps of that?
We will check the airway if there is any obstruction.
Right. Open mouth.
Yeah. Jaw thrust.
Okay.
So if the patient is suspected cervical injury, we will do it by jaw thrusting.
Right. Check in for blood, foreign body, anything in the airway. Thereafter, what we can do? Suppose there is no foreign body in the airway, or large amount of blood in the airway, but his saturation is not going up, his patient is actually not breathing. Then
We have to
airway devices. Yes, it is right. We mean AMBU and think about securing a patent airway. Suppose you have already secured a advanced airway. There is an endotracheal tube in. You are AMBUing the patient. What next? What do we move on to next after the airway? Airway, and you are AMBUing the patient, so the breathing is all right. Then
do an ABG or
ABG is an advanced
PET
test.
CO2.
Now, what's the step? Circulation. How do you assess circulation?
BP and tissue perfusion,
Even before BP.
capillary.
Pulse, check pulse, yeah. Check the peripheral pulses first, then the central pulses. Go in for BP, right? That is assessing circulation. Now, what do we have to do? Circulation is inadequate. Suppose very thready peripheral pulses, BP, maybe you are getting a single knock at 60 millimeter of systolic. Then patient is hypotensive. Shock or no shock? Yes, definitely this is shock. What do you need to do? We need to give fluid, maybe crystalloid, colloid, blood, anything. So start with crystalloids. So for that we need an access. What way we can obtain an vascular access?
It's better to do with an 16 gauge channel.
Exactly, 16 gauge peripheral vein. But suppose you don't have a peripheral access, you can't get a peripheral vein running, then
Jugular. External
yes,
jugular.
not external. In a situation where you don't have it, this is also a peripheral vein, right? So you need to access a central vein, maybe a jugular line, maybe a jugular vein, maybe the femoral vein, or in cases maybe the subclavian vein also. Is there any other way to give fluids, medicines?
Medicine we can give through endotracheal 2, 82, endotracheal 2,
Yes.
and intraosseous means
Yes.
from
Intraosseous also you can give equivalent amount of IV fluid if you get an intraosseous line. We don't usually need that. It's very rare.
I never seen that.
Yes. Most of us, for most of us, it's entirely theoretical. Intubation done. We are ventilating the patient, or we are making the breathing by bag mask, or may have attached the patient to a ventilator. Now you see the saturation is still not going up. We have an advanced airway in situ. You are bagging the patient, or maybe you have attached the patient to a ventilator, but saturation is still not going up. Okay. So on auscultation, you see there is absent breath sound in one side of the chest. Yes. What are the situations where it can happen?
Pneumothorax maybe.
Pneumothorax 1. Pneumothorax is accumulation of air inside the chest wall. Any other?
Hemothorax.
Yes, that is accumulation of fluid. Any other?
Maybe we can put stage.
Yes, that is the first thing. Your endotracheal tube may have migrated down one side of the bronchus, maybe right or left main bronchus, so you have a one lung condition. Now, say we have talked about air first. Now you have a pneumothorax. How do you suspect there is a pneumothorax other than just what is given is breath sound? Emphysema is one condition associated with pneumothorax where air leaks under the skin, right, in the subcutaneous tissue plates. Case takes several, it will take time. Case takes will take time. But just by clinically examining, we have what we have. Upfront we have already done. There is diminished breath sound to one side. Now, patient saturation is not going up, but we are doing the artificial breathing. Now, how can we understand this pneumothorax? Since any clinical inspection, so by palpation, can we find this pneumothorax? Rib fracture is another thing. From the very basic of what we do is we assess respiratory system examination after you have examined the mouth and the upper airway. You assess here, right? When there is a pneumothorax large enough to give you maybe subcutaneous emphysema or maybe completely absent breath sound on one side, what will happen is there may be tracheal shift. Tracheal shift কোন দিকে হবে? To which side? Suppose you have right sided pneumothorax, then tracheal shift will be towards left side. Simple. Air pushing the trachea in, pushing the mediastinum, right? Is there any other way of any other way of finding pneumothorax? Yes, percussion. The percussion, right? Suppose along with this pneumothorax, patients you have any other injury. Abdomen is soft. Patient there is no other long bone or even pelvis. You have done a basic assessment and there is but patient's blood pressure is possible. You have diminished breath sound on one side, right? Your trachea is shifted to the other side and it has diminished blood pressure, very low blood pressure. the tension. So, yes, you may take a, just a second, please. Ah, acha. So, where do you put the needle? আরে আর বাকিদেরও একটু পার্টিসিপেট করতে হবে. Where do you put the needle? Because even before you can prepare for a chest drain or maybe a pigtail catheter, you have to release the tension pneumothorax, the large amount of air that has accumulated inside the chest wall, and that is causing the impairment of cardiac filling, right? Heart cannot get filled with blood, so there is hypotension. So how, and he has said we take a needle and do a needle aspiration. Where do we put the needle? It's done in the second intercostal space, which is in the mid clavicular line. You take a wide bore needle and you put the needle in. Usually what we do is we attach a wide large syringe, maybe a 50 ml syringe. With that there is some amount of air in it and with the piston removed. Or maybe first you aspirate, you put the needle in, then attach it and take the piston off, put in air. What happens is air will bubble out through it. The simple reason for putting air is the same reason we put in a water seal drainage with a chest tube. That is, the air can't get sucked into it. It's a water seal put in that form. Now we have done the cervical spine, spinal board, axial trauma. Any questions? As I said, this is basically a presentation. So it should be a presentation, not exactly a skill station, because I have nothing to work with other than these two things. Any question? এইটা ক্লিয়ার তো? বাকিদেরকে বলতে পারবি তো? One person should not put the cervical collar. One will stabilize the neck and the other person will put in. Anything? Any question? কারোর মনে কোনো কিছু থাকলে, কোনো কিছু জানার থাকলে feel free to ask, please. এখন বোধহয় ভিডিওটা কাজ করছে. How do we treat surgical emphysema? The question is, do we at all treat surgical emphysema itself? Right? What you do is, if there is a pneumothorax, you put in a chest and along with that, you add oxygen. There is no other treatment. Earlier on, people had tried putting lateral striations on skin, hoping that air would come out of it, but it doesn't work that way. It works based on the gas equation, partial pressure of gas in chambers. That is how the air pressure equilibrates. When there is air under the subcutaneous tissue layers, no matter how many skin pricks or laceration you make, air is not going to come out. So you treat the primary condition and give air. হয়ে গেছে, যদি হয়ে গিয়ে থাকে, if somebody has any other question, otherwise I think we have to move to the next station.